So good day to everyone. I'm Candes Carter, and with me is Lacey Latkovic. And together we are representing the Louisiana team for Quartet, which is a technology and health services company. So the big picture for us is to improve the health and quality of life for patients and in turn drive down the cost of healthcare spending for plans so that they're able to continue developing their product offerings. Now, the challenge that we are all too familiar with is that physical and mental health outcomes are linked, but the treatment of physical and mental health is disengaged. And because of this disconnect, mental health care has remained stigmatized, inaccessible, unaffordable, as well as costly on many levels. And so the numbers as well as patient experiences is showing that we have to create better solutions for communities or populations that are flying under the radar. As we turn our attention to this slide, we see that patients dealing with chronic and mental health conditions at the same time drive 42% of total healthcare spending utilization in the US. And so that's a 1-to-2 ratio. And because the overall healthcare system does not operate on a collaborative platform, the 17% of the population living with comorbidities, their individual plan and emergency room spend is 2 to 3 times more than members with just a medical condition. And so we can conclude that members are receiving inadequate mental health care 70% of the time at primary care physicians or at the emergency room department levels alone without collaborative care. And so there is a need for an intervention, a solution that connects members to the appropriate care at the right time to address their mental health conditions. And Quartet is the solution for these challenges. That is why we partner with health plans and systems to facilitate access to care and collaborate to ensure the best health outcomes for our patients. And so we are scalable and we work across lines of businesses, including the Medicaid market. And so Lacey will do a deeper dive into our solutions.
Good afternoon, ladies and gentlemen. Again, my name is Lacey Latkovic, and I'm here with Quartet. Candace and I are partnering on this presentation. Candace, thank you for the group. We are on slide 7. So Candace gave you an overview on who we are, our mission, and what we stand for. As she mentioned, what we want to do is make sure every patient gets mental health care wherever they are. We work with both commercial payers and Medicaid MCOs. So we do the following 4 things. We identify, we engage, we coordinate, and we collaborate. So when we work with health plans, we get a series of claims data that helps us to find patients who are high need, high cost, and require high touch. And I think arguably we could all say that that is a lot of our Medicaid patients. Well, and what we do is we conduct behavioral health assessments on those patients, and then if they score a certain score or they want care, then we get them in care. Also, we engage with patients through what I like to call the legacy method, through PCPs, case managers of these plans, and specialty providers such as OBGYNs, oncologists, any type of physician where you would feel like there's a captive audience for that patient. I like to give examples. So for example, let's say Lacey sees her OBGYN, every 3 years for her regular checkup. And she's demonstrating what's clear depression and anxiety from multiple tours to Iraq. The OBGYN is probably going to recognize that, but is probably not going to be super comfortable with treating and or providing the therapy for that person. And historically, what we've seen is that the physician will say, for instance, I think that you're suffering from XYZ. Take a look at the back of your insurance card and give your insurance a call and they'll match you to a provider. We take that onus off of that physician. And what we do is we use SmartMatch algorithm and care navigators to right there with that patient who is ready to go to care. We put them in the referral system, and within a couple days, we match them to the right provider. So what is the collaborative piece? So we're matching physical and mental health. So let's say when I go to my first appointment, I'm also demonstrating an issue with sleep, insomnia, etc. The MHP can put that note into the system where the PCP can read it, and they can collaborate on whether or not Lacey actually needs a sleep study for her overall well-being and health. Next slide, please, Candace. Okay, so how does this work? What do we have to offer? So I like to call this kind of pre-COVID, current COVID, post-COVID. So pre-COVID, what you're seeing right here are the care pathways that we've provided. Predominantly, we were using in-person teletherapists and in-person teleprescribers. That has vastly changed, obviously, since COVID. And I can't remember who it was, but it was before we went into the presentations. One of the gentlemen said that there's got to be a healthy balance, right? You didn't think it was going to be completely 100% virtual or completely 100% physical. And I think that is the solution that Quartet provides. We also work with FQHCs. We also help to partner patients with who are suffering from substance abuse disorders. We have online CCBT-based programs, which can be used as standalone and or a bridge to care. So let's say we have a patient who has unique circumstances and a lot of variables. We can offer that as well, provided that they're inclusive to that program. And that patient will always have their login and can dial in their phone at any time to go through any of those modules. Additionally, we have a curbside consult. So in Louisiana, for instance, when we have PCPs who are working out in rural communities, and let's say they are comfortable dosing for mild to moderate depression or anxiety, but perhaps the patient has significant comorbidities, is taking blood thinners, is a diabetic, or they just simply want to titrate to or from a certain psychotropic drug, they can phone a friend and peer-to-peer and have that consultation within 24 hours. Next slide, please, Candace. So what makes us different? So that gave us the kind of who we are, how we got there, and what we've done to date. But currently, if you're looking at slide 10, you see a series of what I like to call honeycombs. So we've drastically changed our way of doing business with our Medicaid population for a number of reasons. Number one, we found that predominantly they don't really go so much to PCPs. They are a lot of hard to reach patients and working with FQHCs. So we want to meet them where they are. We want to service these patients. And then so with COVID, we had to get really creative with our telehealth strategy. So right now we're offering both tele and physical care. However, we're leaning towards tele right now because we want to be part of the solution, not the problem. But as soon as we get more clearance in the country for face-to-face, we will provide both services. So right now we are using, like I said, health systems and case managers, health plan case managers, FQHCs, and also utilizing some other avenues of discharge. Let's say, for instance, the patient's in an ER or IOP program, and they need to be matched to providers, housing, care, etc. Post that discharge, we are the solution for that. We can put that patient into the system and match them to a mental health care provider. We are also using, very robustly, the health case manager program, because those case managers are already very intimately involved with the patients, and they know their life story better than arguably any PCP. How other ways we've gotten creative in digital outreach is through community programs, utilizing faith-based organizations, support groups, police departments, and even putting physical cards in your baggie at the pharmacy that you're already reading about your medication, when to take it, how to take it. Oh, and by the way, if you're suffering from mental health care, you can click on this link and self-refer if you qualify. And otherwise, we're utilizing Facebook and social media outreach in order to meet our patients where they are. So again, we've had to get really creative with COVID in order to ensure that our patients are getting access to mental health care under all circumstances. Next slide, please. And finally, it's very easy to talk about SmartMatch and data and algorithms and how we do what we do. But I think it really drives the point home when we can demonstrate to you how fast we've actually gotten a patient to care. So this is just a timeline really quickly of a Medicaid patient who attended an appointment in 6 days. So I would say before COVID, we were matching our patients to mental health care at roughly 12.5 days. So this is great. With telehealth, we've seen that number decrease significantly due to the utilization of telecare. So this is, again, the legacy approach, but this is the PCP who submitted a referral on the 23rd of May. The patient was actually matched to a mental health care provider on the same day. That appointment was also scheduled on the same day, but was not scheduled until the future. The patient attended the appointment on 28 May. And furthermore, they continued the relationship, and the patient continued to take behavioral health assessments and schedule a follow-on appointment. Next slide, please. And finally, in conclusion, I just want to give our information out there. We should have maybe a few minutes for questions as we sped through that. A lot to learn in just a few minutes. But again, my name is Lacey, and you met Candes as well. She is the account manager in Louisiana, and I am the general manager in Louisiana. And we partner with health plans, Medicaid MCOs, and health systems to get patients access to mental health care and drive down costs. I'll pause there for questions, comments.
So what does your implementation model look like at a provider versus a payer? And how do you integrate with existing behavioral health services that have strong case management services?
That's a great question. So, and this is really more on mine and Candes's level. So what we do is we get data from our plans about where the membership is. So we want to spend our time. I have a small field team, sort of like I would say a pharmaceutical sales role or medical device sales role, where we go to primary care doctor's offices where there's a high membership of the client that we are engaging with. And what we do is we talk about our platform. We talk about why mental health care is needed and how easy it is. And also we can integrate with EHR. So that's the model that we have used historically. We're only about 5 years old, and we use that in the commercial payers as well. In the Medicaid side of things, we are really getting creative, being faster, quicker, stronger up front. As you can see, that would take time, right? Candes and I going around, meeting primary care doctors, talking about mental health care, and just getting on their very, very busy schedules is challenging. So we've gotten really creative now. As soon as we sign on with a plan, we talk about rolling it out with case managers from the beginning. So we start to treat the case managers like we used to treat a PCP, if that makes sense.
Great. And last question, can you talk about what you've been seeing during COVID-19? Has Quartet seen behavioral health utilization change?
Oh, absolutely. So when we utilize claims data to try to find these high cost, high need patients, before COVID, that was really challenging. Say if you're a patient, say I'm at my house and I'm getting a phone call and asking to take a behavioral health assessment, I might get freaked out, right? What is this? Is this the government? Who's calling me and why? But we have a lot of anecdotal evidence now from our care navigators where the patients who are now getting these phone calls are so much more primed to talk very lively about their life, their anxiety, their depression. Oh my goodness, my kids are at home. Oh my goodness, I lost my job. How am I going to pay for food for the end of this week? And just take care of all the things that have changed with COVID. And oh, by the way, COVID itself, just staying healthy is fear for people, not being able to travel, sort of staying at home and just being isolated from day-to-day activities. So we have found that the need for behavioral health was always there. But as Candes mentioned, the stigma, I think, has been largely sort of erased with COVID. So I think that's been a really beautiful thing for behavioral health in the future of it.
Great. Thanks, Lacey. Thanks, Candes.
Sure. Thank you.